and Mr. Smucker, you're recognized.
Thank you, Mr. Chairman, for holding this important hearing, and I'd like to thank each of the witnesses for sharing your testimony today. You've explained how important post-acute care is, how vital of a role it serves in our nation's healthcare system, with roughly 40% of Medicare beneficiaries receiving this type of care after inpatient hospital stays, and we've also talked about how that helps them to recover and stay healthier for longer. I've spoken to constituents in my district about the services that they've received through skilled nursing facilities, home health, patient rehabilitation facilities, and other care settings, and understand and agree with the importance of continuing to make improvements to the Medicare program so these services continue to be accessible for all seniors. I'd like to highlight just a little bit the LTACs, or long-term care hospitals, which serve the most complex patients who are in need of specialized care but are facing waves of closures. I've heard that from folks in my district as well. And these are the hospitals that, or if these closures continue, the most patients with the most severe conditions won't have the level of care that they need. We've heard reports of Medicare Advantage plans delaying or denying coverage. You've mentioned that earlier today for LTAC services. And why I believe that MA has been a game changer in allowing seniors to that access to better, more comprehensive health coverage. I'm concerned by some of the obstacles to care, which could lead to costly complications for patients. So, Mr. Dungilly, we've heard a little talk about prior authorization just a little bit ago, but can you describe some of your experiences with prior authorization and talk about how those may create barriers to coverage and how that impacts the care that your patients receive?
Yes, thanks again for the question. The delays once an assessment is done on a patient who has Medicare Advantage and working through the appeal process is time-consuming and resource intense. It delays that patient's access. And at times, the patient then and the hospital that's referring them may not want to work through that process with us. And so as a result, we'll discharge the patient to a less intense setting where they don't receive the care that they need, or they stay in the acute care hospital and create throughput issues for that hospital because they can't discharge them.
So it literally could lead to patients being required to leave your facility and not receiving the care that is needed.
Correct.
Yeah, I appreciate you sharing that. I'd also like to touch on home health as well. We know that patients recover quicker, have better experiences when they receive care in their homes. Occupational therapy is one of the services that seniors can receive through the Medicare Part A home health benefit. However, as you know, the outdated statute prevents occupational therapists from treating a patient in their home unless they're accompanied by another provider, which creates a strain on medical providers and complicates this access to care. Yesterday, I introduced a bill with Mr. Doggett and several other colleagues to streamline the process and allow occupational therapists to provide standalone services in the home health benefit. Dr. Madison, you also noted in your written testimony that on average, one 60-day period of care of home health costs less than one treatment in an emergency room. So I would think there are huge cost savings here. So Dr. Madison, how would a bill like the one I've described streamline patient access to care? And can you expand on the financial implications this would have for the Medicare system?
Yes, sir. We're paid for an episode of care, regardless of what services we provide. However, if OT could stand on its own, then an OT could provide all the services needed instead of a nurse having to do the admission and the discharge. So it would.
Can you give any sense on what kind of cost savings that would create?
It would not, because we get paid for an episode. We get paid based on the diagnosis, the function of the patient, that kind of thing. What it would save is the expenses that the agency is having to spend.
Yes. All right. Thank you. Mr. Chairman, I yield back.